And on the November 17th, we are going to have next week, we are going to have a very, very nice talk about how pediatric cardiology is done in another part of the world. We are going to have Dr. William Novak as our keynote speaker to talk about his mission trips in war places. So war zones are something that we usually don't think about the kids who are living there and who need cardiac surgery. And he has been doing a great job, as well as another colleagues from Iraq, Libya, Yemen. So please join us on that. This webinar is going to be a joint a webinar with the Pan-Arab Congenital Heart Disease Association, and then we are going to discuss some issues of the Arab world and how we deal here with the congenital heart disease patients. So please join us. This is going to be a very, very special session, a session that comes from our hearts. And now with you, Dr. Gilbernovsky. Thank you, guys.
There's the obligate, oh, I'm muted, and can you see my slides? So let me just see if I can share my screen here. Hold on one second. This should do it.
And guys, don't forget to place your questions if you have some on the Q&A box and talk to us on the chat box. So we are going to be very happy to interact with you. And now Gil is going to tell us about our pool, how we're going to do this. It's going to be so much fun.
All right, so my slides are over here. My camera's over here. That's what happens when you have multiple screens. So I apologize about that. I'm happy that the Congenital Heart Academy is an educational sponsor of the World Congress of Pediatric Cardiology and Cardiac Surgery. I wanted to just give you a brief announcement. This was scheduled to take place in Washington, D.C. in September of 2021. But because of the pandemic and a variety of other travel restrictions, we have decided to move the Congress to stay in Washington, D.C., but to take place at the end of August. The dates are August 27th to September 1st, as you can see there. And we have just a little brief video about this. Do I have sound, I hope, Grace? If anyone's interested, this is the propeller heads of the Congress.
You can't see it.
You can see it?
No. From the screen. We see your PowerPoint, but it's not on presentation mode. It's just the first slide, not on presentation mode.
I can fix that.
That's the problem to have multiple screens.
Yep, it sure is. Let me unplug this one. So this is the fragility part of my presentation, I guess.
No, we lost your video.
Can you hear me, Grace?
Yes, we can hear you, but we can't see you anymore. We lost your video.
Well, that's probably better, don't you think?
I don't think so, no.
What about now?
Now we can see your screen. You're moving your mouse on the PowerPoint. Let's see if when it goes to presentation mode, we can see it. Not coming yet. It's not coming to presentation mode.
Okay, so this is the problem with multiple screens and for me logging in too late, and I do apologize to everyone. Let me see what I can do here. Hold on one sec. Disconnect that. Now I should be just on one screen.
I would advise you to unshare and then share again.
How's that?
Yeah, now it's working perfectly, but we can't see you.
Good.
No, it's not good. We want to see you.
Okay, I will see if I'll try that. And there we go, start video. Okay. That should be good. All right, let's start again. That's started out fragility, now it's resilience. So we're going to have a poll in about 10 minutes. And if you could use your phone, if you're not on your phone, or maybe open up another web browser, if you wouldn't mind logging into AHA slides /yin yang. And I'll put this code up again in just a little bit, but we're going to have a quick audience poll, get a handle on sort of who is attending and those sorts of things. We had a lot of registrations. There may have been some problems logging in. And let me just move this. And as I mentioned before, the World Congress is going to be postponed and is going to move to August 27th to September 1st, 2023. And I'm going to skip the video just to catch us up in time. I'm also really pleased. The lecture in the series that is scheduled for December 8th is now going to be expanded to include 3 just tremendous speakers talking about things they're very passionate about. I'll be talking about cognitive dissonance, which is particularly important to me in bringing research and change of practice into intensive care and outpatient cardiology. Merrill Cohen from the Children's Hospital of Philadelphia will be giving a bit of a historical review and current perspective on women in pediatric cardiology and cardiac surgery. Sarah Teal from Children's in Boston will be talking about incredible work she's been doing up there with the MGH program on teamwork and training. And then finally, Dan Penny, who's the chief of pediatric cardiology at Texas Children's, is going to give a lecture you really don't want to miss. It compares leadership to a whole bunch of other industries, particularly music, and I think you'll really enjoy that. So we're going to talk today about the yin and yang of fragility and resilience. I had the pleasure of putting together most of this for the Anthony Chang lecture at Pediatric Cardiac Intensive Care Society a number of years ago. We had registrants today from 71 countries, and as we're learning with a little bit, I guess, of webinar fatigue, that most webinars now are getting about 40% of their registrants. Things pick up at work and things that are not predictable, especially with the ones at no cost. I was particularly excited about all the countries that are joining us from the African continent, people that are joining us from the Middle East, from India, et cetera. And this is not meant to be read. This is meant to show the variability of where these Congenital Heart Academy lectures are now reaching. And I suspect in many cases for people that would not have the chance to attend a international meeting. So we're very pleased that this has been working out. I have no disclosures. I'm going to be talking a little bit about some definitions, and then the short and long-term effects of intensive care, particularly length of stay, and then some strategies to think about to improve our patients and our families and ourselves through this process. So how do we define what we do? What exactly is a pediatric cardiac intensivist or cardiac ICU nurse or an advanced practice provider? There's really no definition, so I made one up, which is someone who dedicates their clinical practice to the care of critically ill children with heart disease. Some of you may have heard this in other parts of this series. And there's a lot of similarities between what we do in cardiac intensive care and other types of intensive care. And there is a quote that I saw in one of the ICU journals that said, intensive care is resilience in the face of chaos. I loved that definition because some days certainly seem that way. And the similarities are more common than the differences between neonatal, pediatric, cardiac, adult, neuro intensive care. And some of the stressors we're going to talk about today are particularly similar. I want to change that quote just a little bit to resilience in the face of fragility. What do we mean by that? Well, resilience is a concept of relative stability. It's the rate at which a stable system returns to a steady state after a perturbation. And I'll give you a couple examples of that. So if you look at a theoretical graph of a patient's clinical course, you might see this sine wave type pattern. And the ability to return to a steady state, whether that's lactate measurements or blood gases or whatever, is termed resilience. Fragility, on the other hand, is not really quantifiable. So it's therefore not simply the opposite or the antonym of resilience. Rather, fragility refers to the idea that some parts, if not the entire whole of the system, can be damaged relatively easily. So while resistance does that, fragility does this. And fragility, depending on the severity or the degree of fragility, may bring the system failure down sooner rather than later. And I thought I understood that pretty well until I read this book by Nassim Taleb. He's also written The Black Swan. And he had a 4-volume essay on uncertainty. He's really worth a read if you haven't read his stuff. And he has coined the term anti-fragility as a property of systems that get better over time, that increase in their capability, resilience, or robustness as a result of those stressors or shocks or mistakes or things that happen to us in intensive care in particular. It's one of the concepts behind artificial intelligence, constantly learning from changes within the system. And that's fundamentally different from the concepts of resiliency, which we've talked about, from robustness, which is a robust system, the ability to resist failure. A good example there would be a baby that comes in very well nourished, maybe in a very rich country compared to the malnourished baby that comes in countries without the same types of resources. So Taleb stresses this difference between anti-fragile and robust and resilient, and states that it's sort of beyond those two things. Resilient resists shocks and stays the same. Robust does not perturb the system as much, but the anti-fragile gets better over time. So if we go back to our own theoretical graph here of resilience and fragility, if you have an anti-fragile system, if you look at the line in the middle, that system improves upon itself, improves upon resilience to get better. I certainly would think about a baby that has, for example, heart failure with a large ventricular septal defect as having a bunch of fragility, but you close that hole and that patient now becomes anti-fragile. So if we take that now to management, patient management, day-to-day intensive care is geared at promoting this resiliency. How many times do we hear the baby's back to baseline, or the patient is stable, or there's no change? And that is resisting and treating the fragility part, keeping them from getting worse. But clearly our goal should not be that way. Many people have said in our field that if you're stable, you're going backwards. And I'll give you a couple examples of that later on. That's sort of in our day-to-day work. But if you think about our field in general, we really should be striving to define and implement anti-fragility models to our care systems so they get better, our research so we practice better, and collaboration between units. So if we looked at what the title of my talk was, resiliency and fragility, or brittleness or vulnerability, this is an or. You really can't be both resilient and fragile. I'm going to actually say that's not true. I'm going to show you some examples of that this is an and, that you can have both resiliency and fragility within the same system and at the same time. And that's where the concept of yin and yang come from. In Chinese philosophy, it describes dialectical thinking, how seemingly opposite or contrary forces may actually be complementary or interconnected and interdependent from the natural world, how they may give rise to each other. And my colleague and one of the pillars of pediatric cardiac intensive care, Dr. Anthony Chang, when I was speaking with him about this talk, he said, yes, it's like a strand of DNA. You think about your emotions, you're not just one emotion. You could be both happy and concerned about something else at the same time. So this interaction influences the destinies of creatures and things in Chinese philosophy. One is negative, dark, and sorry about this, feminine, which is termed the yin. And I know Jeff Bird's going to get on my case for that one. And one is positive, bright, and masculine, or the yang of the yin. And it must be true. I read it on the internet on dictionary.com. So what does this mean in our intensive care unit? What does this mean for our patients? Can they be both fragile and resilient at the same time? So here's an intubated baby doing his own mouth care. That's pretty resilient. What about this little boy who's walking with his ventricular assist device? He's on a ventricular assist device. He's pretty fragile. But look at him. He looks pretty resilient to me. So that's an example of a yin and a yang. Families who seem to be holding it all together when in the back they're fragile as can be, and won't show it. But we'll talk a little bit about how true that is, even once they leave the intensive care unit, what's going to happen next. And then, of course, at end of life, this particularly comes to bear. And I have to tell you, I forgot to mention this at the beginning, but I have permission from all of the families of these patients to show you these images. I also have a picture of, I have permission from Bill Gaynor, who's the surgeon operating over there in the cardiac ICU at CHOP. We are also resilient and fragile at the same time. We have a tough job. There's a lot of sick kids with what we do. I think this is the most obvious example of resiliency and fragility I could think about, right? I don't know how the nursing staff can organize that. It's an incredibly fragile system with an incredible amount of resiliency. So that's what we're going to talk about for the next half an hour, 40 minutes. And if you could, again, I'm going to ask you to log on to AHA slides /yin yang. And I'm going to see if I can get this.
Missing, I guess.
I'm sorry, say again, please, Grace.
There's a .com that is missing. It's ahslides.com/yin yang. It's on the chat box, and anyway, the link is on the chat box.
I want my slides to be right,
That's correct. Very good. But it's in the chat box, guys. Guys, if you want, just click there and get the link.
Thank you. Now I'm going to give you a new share. And I think that's here. Okay, so you should see, let me just get into my present. Okay, so just as a practice slide, I'd like you to please identify the birds. This will get you used to how the screen works. You'll need to log into the next question when we go. We have about 42 of the participants. We have 107 participants. So we'll see how this turns out. I'll give you just a few more seconds to get used to this. And on your left, of course, is the eagle, which of course is the Philadelphia football team. In green is Larry Bird. I don't know who thought the porpoise was a bird or the dolphin. Charlie Parker is over here, who's known as Bird, great jazz person. And on the right is a very young and svelte Jeff Bird, a cardiac intensivist at CHOP. So let's move to our next question. How'd you hear about the webinar? Just so we can figure out a way to maybe better meet your needs. You'll have to hit to the next slide. And again, we have less than half of the people on the poll. If a few of you could pull up an alternative source, we'd really appreciate it at the Academy so we can improve how we move the lectures forward. Okay, this is pretty typical to what we've seen in most of them. I was frankly surprised. Most people hear about this through good old-fashioned email. Okay, where do you live? Please, we'll get an idea of the distribution of people. We're trying to decide if 11 o'clock a.m. or 7 a.m. Eastern time or evening webinars are more popular. We have about 53 people that are logged on, most of you from the US. And although we had a number of people from India, it doesn't look like registered anyway. They'll probably look for it on the YouTube channel a little bit later on. How old are you? That's me, by the way. I did this first just to be sure they were working. And our historical ones are yellow and green, are the two most common age brackets of people who've logged onto our site. I'm going to go in another second, and we get to the fun stuff in just a second. Okay, so that's similar to what we've seen before. This sort of stuff is helpful for those of us who speak, because now that we're doing this on Zoom, you have to sort of imagine what your audience is and where they're from and maybe what their native language is and things along those lines. Just 5 more seconds on this one, and we'll keep that as a poll. Okay, what do you do in your practice? What's your day-to-day practice? All right, so a lot of cardiac stuff, some fellows, 3 surgeons. It's amazing they're out of the operating room. All right, so about a third are pediatric cardiologists, more than half for cardiac intensivists, physician in training, and other. Is it possible we didn't have nurses on this list? Because I know a few have registered. Okay. Next is, here we get to some of the interesting questions as we get into fragility and resilience. I feel supported by my coworkers. Which certainly can add to the stressors of a system. And that's very nice to see that 2/3 of us are frequently or essentially all the time supported by our colleagues. All right, I hope this worked. This is the first time we're trying this, which is where you're going to go on a Likert scale from being fragile on the left to being totally resilient on the right. This is a brand new thing that the AHA slide system has started to use. It's fascinating, actually, when you think about it, where the moving average is. So 6 was, I remember the number 6 was the text that went with it was pretty good. Is this showing up on the screen? Grace, is this showing up on the screen?
Yes.
Okay,
yes.
Good. Thank you. Because there's a couple that are hidden. Here, what you're all familiar with is the pain scale that we use at work. This is a little bit different, just to get, instead of a quantitative number, how you feel at work. There's the second highest rate of burnout is in intensive care, both in adult and pediatric. With emergency room always being the number 1 in those. And how we feel supported and how we feel at the end of the day goes a long way in terms of the sustainability of our job. And Dr. Bird and I at the upcoming PCICS meeting, I'll put in a little plug for that meeting, which is pcics.com, which is the virtual meeting, are going to have a session with the trainees about trying to minimize the chance of burnout. And I'm really looking forward to that. Okay, how many of you think you're going to be doing the same or a similar job in 5 years? This is the first time we've asked this question, so I had no idea what to expect. So there's quite stability there in the majority of us there, it looks like. Just a few more questions. Appreciate you getting involved in the survey. There is 50 of us right there, 51 of us. How about in 10 years? That no is me, by the way. I will be happily on a beach somewhere, hopefully in Sicily. Mainly at Dr. Agati's house, if I can do it.
I promise, you know.
We've been talking about that enough, Sasha. That would be great.
You have to put a poll about this.
All right, it looks like I'm coming with 7 of my best new friends. So we'll be there.
Yes, most welcome.
That's great. All right. Well, these are going to be interesting things to look at. Are you happy most of the time? Just a happy group on balance. We're in the middle. This isn't a pandemic, and I am really encouraged to see this. It's been a tough time for mental health for a lot of people with this pandemic, so that's very reassuring to see. How about at your job? This is, generally. That's pretty similar. I'm going to have to compare those two slides. So this is at work. And this is what we usually are. So that looks like for some of us, work may be a little bit of a stressor. Okay. All right, this should be fun. Please put 3 words down for 3 things that are important to you, not your work. The word clouds are always interesting. Wine popped right up there. That's good. A Jeep, activism, family and friends and health. That really comes in quite a bit. And that's not losing its position. And boy, is that reassuring to see. We do have both religion and spirituality in there. And the frequency with which the word comes out is how these word clouds go. Fun. I thoroughly enjoy seeing these as we go along. And then the last one is, these were the 2 I put down for myself. If you could put in, all right, you're not going to be a healthcare provider. What do you want to be? Pro athlete, that's got to be Jeff Bird, I would think. Wedding dress store owner. Oh my gosh, is this fun? Somebody put Wernovsky. Trust me, man, you may be careful what you wish for. Oh man, I love this. Thank you all for doing this. Sasha, what did you put down?
Yes, I put Bernowski because I know that. and I put musician.
Nice.
Yes.
How about you, Grace? Grace, what did you put down?
I couldn't write anything, and this is something that caught my attention. I had never thought about being something different, and I have absolutely no idea what I would do if I was not a physician.
All right, the next 15 minutes, you're going to have to decide, okay? All right, I'm going to put my slides back on, and we'll go for the next 30 minutes or so. So if I want to do that, thank you all for doing that. That's always a little bit of fun. So let's talk about our babies and some of the things we put them through. Surgery, of course, that's a pretty stressful thing. We're going to talk about a little bit of these things as we move along. Certainly fragile. We hope that the babies have resiliency, and despite, surgeons operating on something that small, this is at the time of a transplant, of course, the overwhelming number of our babies survive. So despite going through this incredible amount of complex stuff and small hearts and machinery and whatnot, the babies are pretty resilient to the surgery. But what about what many of us do, which is the ICU course? And many of you have seen this graph, which is where you have pattern recognition. This looks to me like the perturbation of a system getting back to baseline. And in this particular case, this could be, so some curves look like that, some curves look like this. I'll see if I have some labels on them. What changes is the shape of the curve, the item that you're measuring, and the time frame. But for the most part, what happens in intensive care unit follows a particular path. Hopefully, lactate does this, and urine output does this, and cardiac output does this. So cardiac output, we know, falls and then rises. Now, this hasn't been duplicated in a number of years, but I think our clinical experience would suggest that still between 6 and 18 hours is when we have to be particularly mindful of what kids do in the operating room. The point I'll make about that, as well as the elevation in systemic and pulmonary vascular resistance, which goes with that, is by 24 hours, these kids have returned to baseline for the most part, which is a real tribute to their resiliency. And it's also, most kids at that point can start to have all their stuff removed. And we're going to get back to why that's important in just a second. If we look at a couple of other things that follow a curve of fragility and resiliency, this is over the first 5 days. The pink patients have transposition, the bluish patients have hypoplastic left heart syndrome and a Norwood, and their fluid balance has a fairly predictable course. Their hematologic parameters like white blood cell counts and platelet counts follow a fairly predictable course. So when you have a system like this, the baby's physiologic system after a good repair, this is what your expected yin and yang of fragility and resilience should look like. And if it doesn't look like that, and the baby is more fragile than they should be, that's the time to investigate their repair. You've all seen this at the bedside. This is an example of heart rate at the top and saturation in the middle, and the respiratory rate in an intubated patient who gets suctioned. And generally, after that physiologic stimulation, the babies are fragile and then are resilient and again return to baseline. We know at the time of sternal closure, and if you haven't read this stuff, there's 2 studies at the bottom that are 14 years apart. 24 years apart, that showed almost exactly the same thing, that as you close the chest within the first 5 minutes, mean arterial pressure goes down, the cardiac output goes down, the stroke volume goes down as preload decreases, dynamic lung compliance goes down, the central venous pressure goes up. And most kids tolerate that pretty well and are pretty much back to baseline in an hour or 2. The price we pay is the risk of infection. So there's some fragility there and resilience, but then there's this concept of long-term fragility from these particular stressors, which we're going to talk about also. It's tolerated. Delayed sternal closure is tolerated in most patients. I think it's time to investigate whether elective delayed sternal closure has more efficacy than safety problems. I don't think that's been studied well. So to summarize this part, neonates and infants are remarkably fragile and resilient to short-term stressors, but they're particularly fragile to longer-term stressors. We talked about delayed sternal closure, but I want to sort of lump that into the concept of a prolonged length of stay. We know that both the patients and their families will be affected considerably the longer the length of stay in the cardiac ICU. For the families, there's financial hardship, there's family stress, there may be neglect of some of the other siblings, and an increased risk of post-traumatic stress disorder. For our patients, there's a risk of infection, there's a risk of medical error, and as has been shown in virtually every study looking at long-term outcome, worse neurodevelopmental outcomes. We know that these are the challenges that children have. It's been studied now for about 25 years in terms of early motor, later school, and then finally anxiety, depression, social cognition, things along those lines. And not all babies have this, not all kids have this, but somewhere between 25 and 50% of the cardiac ICU survivals will have one or more of these neurodevelopmental problems. The causes are multiple, as you can see here. But in addition to socioeconomic status, the most consistent risk factor for abnormal long-term development is the duration of hospital stay, which is a summation of all the things that can make someone fragile, that we induce on their care, frequently because it's life-saving, but it also could have a downside. This is work that was done in the Boston circulatory arrest study a couple of decades ago now, where if we broke down the IQ at the age of 8 after a neonatal arterial switch operation into quartiles, verbal is in purple and full scale is in this blue color, that the longer the children stayed in the intensive care unit, when adjusted for a variety of other factors, the worse they did on a cognitive test 8 years later. That association remains strong and significant. And this is important because this is a modifiable risk factor, as I show you, as well as other variables. In this particular study, not been reproduced yet, once you take out the outliers, for each day in the ICU, there was about a 1.5 point fall. This is above the median in full-scale IQ and math achievement. This relationship, though not the depth of it, has been shown. This was Bill Malley's paper comparing transplant and Norwood's for length of stay. And what is it about length of stay that's so powerful? Can we modify it? What is the fragility resilience ratio? How can our field over time become anti-fragile in this area? We know that the longer we wait toward surgery, which adds to length of stay, the more white matter injury that can accumulate in the brain. So is a baby really stable in prostaglandin? We've talked about this in the last couple of series. We know that the amount of anesthesia and narcotics that they receive in this early age is related to poor neurodevelopmental outcome. This is a retrospective study by Dean Andropoulos, and I'm running through these quickly on purpose because they will be on the YouTube channel if you'd like to look them up. But in particular, longer ICU length of stay, shown there in the orange color at the bottom, after adjustment, went along with worse neurodevelopmental scores at a year, along with what changed on the MRI and, importantly, a greater amount of anesthesia exposure. In a replication cohort at CHOP, Laura Diaz showed exactly the same thing, as well as 4 years of age, looking at all. So Dean's study was at a year of age. Laura's study looked at 4 years of age, and all of these important things for kids when they get to school were significantly worse. The more anesthesia and narcotics, interestingly, as well as benzodiazepines that they had. In addition, there's some other studies here that I'm leaving up here on the top, which was cognitive impairment shown up above from Korea. And then if you look at things that are increasingly being measured, certainly in the US, which are scales of family satisfaction, the average score on a scale of family satisfaction was lower, depending on how long one stayed in the intensive care unit as well. So what are the other cumulative exposures? We've got anesthesia, we've got narcotics, we've got benzodiazepines. Then there's plastics. The phthalates are part of everything that we use that's squishy, like in these rubber ducks here, but they're in everything. They're in IV bags, tubing, umbilical lines, IV catheters, Foley catheters, endotracheal tubes, intracardiac lines. All of these have plastics which leach out into our patient's blood system. The first study that I know of that looked at this at 2016 used both a validation cohort and a replication cohort to measure the metabolites of these circulating phthalates. And after adjusting for covariates, if you achieve the threshold of a DEHP metabolite of phthalate, it was associated with attention deficit and impaired coordination a year after hospital discharge. In the validation cohort, not only was the ADD association confirmed, but the amount of plastic exposure explained half of the ADD assessed at 4 years after a PICU admission. And there's been 2 recent publications. The first is by the group again at CHOP, who's been really forward thinking here, by Bill Gaynor, published last year, that was looking at the potential neurotoxins from medical devices. And again, you can look this up. It's a fantastic study. The metabolites, the phthalate metabolites are shown at the bottom. There's 5 of them. And you could see that the maternal levels were very low. The infant before surgery had a little bit, but after surgery, dramatically higher levels of these metabolites in their blood system. And also in this study, the urinary concentrations, which is the primary mode of excretion, increased. This was just published about 3 months ago. This is a secondary analysis of a randomized clinical trial led by Eric Graham and others of preoperative steroids, where half of the patients received steroids prior to going on the pump and the others did not. But what Alan and colleagues did here was to also look, there's the publication date if you'd like to look it up, May 6th. What they also did is they looked at, again, these metabolites, these plastic metabolites. And at 1 year of age, the mean Bailey scales, which is a way of comparing a 1-year-old to another 1-year-old or a toddler, it has little predictive validity for adolescent values, but it is a very valid test. The normals are 100 plus or minus 16. You could see that this subgroup actually was doing a little bit better than average, about a half a standard deviation above average. But the mean cyclohexone, again, another metabolite, was significantly increased, as one might expect, in this study, randomized trial of steroids, secondary analysis. But in the adjusted analyses, more cyclohexone was related to lower cognitive and language function. So this is now our second study confirming what was shown in the German study. And there's the adjustments down there. So there's things that we might be able to modify. So if I can give you any take-home message here, reduce the hospital length of stay. If you take the stuff out, chest tubes, breathing tubes, as soon as is safe, then you need less benzodiazepines, less narcotics. You get exposed to less practice, and you get back in your parents' arms as soon as possible. That's going to help the baby, it's going to help the family, and it's likely going to increase satisfaction all the way around. So then we're happy, right? Here's a young fellow getting ready to discharge a patient from the hospital, and there's the mother of the patient, because we're very happy, but this is a very scary time. A number of parents have told me that there's 2 scary times in the hospitalization. The first is when the baby is handed to the anesthesiologist, and the second is when the baby is handed back to them to go home. And it's been shown in a number of studies that increased stay in the ICU in parents results in post-traumatic stress disorder, measurable, symptomatic tachycardia and re-experiencing and fear up to years later after our, quote, well babies have gone home. Facebook's a great way to learn about this. Now, again, you're going to see both ends of the spectrum on social media as opposed to the median. However, it's important to see that tail of the curve. You tend to get the families who brag about how well they're doing, and they drop off eventually. And then you get the families who are really struggling. My 2.5-year-old has her annual checkup. Whenever I go back to the children's hospital, I get anxious, a horrible feeling in the pit of my stomach, find it hard to hold back the tears, and I'm hoping that this will pass with time. 2.5-year-old well after an arterial switch. I have to admit, I would go into that office and think everything is fine, and in the 20 minutes never ask how mom was doing or how dad was doing. There's a little baby with hypoplastic left heart syndrome. You can see some of these words here: intensely angry, I'm crying, the baby is doing well. Is this normal? I didn't think I would be so affected. She is 1 and doing great, but I'm feeling emotional. So we're starting to look at this. This is the good example of resiliency in the short term. We've all seen how well many of our families cope with unimaginable fear. But the fragility in the long term is real, and it's time to address it. And one of the challenges is whose responsibility is it to address it? We don't know that. I'm going to skip these things, but this was a comment, again, on one of the social media things. And you could see there were 90 comments within 20 hours up in the upper left-hand corner. I'm happy the families have found social media to connect with each other, but Bia Latal's group in Zurich has studied this better than just about anybody. And this was looking at post-traumatic stress disorder. You can see that over on the left. It's more common in moms than dads. And here's the things that we can start to think about. Again, longer length of stay, much more risky for post-traumatic stress disorder. lack of social services involvement, and families that come from a distance who lose that tie to the surgical hospital. Now, we know that what goes on in the operating room accounts for 5% of the variance in how kids do on their neurologic examinations up to 10 or 15 years later. However, a quarter of it is explained by maternal mental health. So helping the families, the mom in particular, will help the baby. So the cumulative effects of a long-term CICU stay on fragility includes borderline hemodynamics, a ventilator, anesthesia, maybe phthalate exposure, a bland environment, lack of social situation, oral motor coordination, weight gain problems, parental stress and anxiety. We think that when we send that baby home, that they've returned to baseline, and they may even be anti-fragile, right? They may be better than when they came in. But these families and these babies are very at risk for fragility and other problems long after discharge from the intensive care unit. So how are we going to promote anti-fragility after a long stay? This was a great study that Haley Hancock and others did, where they randomized patients to random care or having the long-term care, what's the word I'm thinking of? Palliative care team go with the families from the beginning. And so many hospitals, palliative care is sometimes thought of as a negative connotation, end of life, but they're also very good for support and defining goals and mission and what the families really like. And they found, I'm sorry, I'll go back here one. They found that at 6 months of age, the moms who had been in the palliative care group had less depression, anxiety, and improved mental health. And then interestingly, though not statistically significant, those that were followed along with the palliative care team had a shorter length of stay. Some of the best stuff in the field is done by George McCusker and Frank Casey in Ireland. And this is, again, just one picture here that they actually randomized these patients to getting an intervention program rather than going home. And this intervention program extended after hospital discharge. Maternal worry went down, and the baby's MDI and PDI went up. So we have a way now to think about anti-fragility during short-term follow-up, and that includes early contact after discharge, the use of telemedicine, and setting up a roadmap plan so parents know when the expected comprehensive evaluation should take care of. And the reference here is down in the bottom right. I will skip through these groups, but I love that picture because it's 7 babies with 7 ventricles and I think 3 G tubes. And they have a play date together. These families have reconnected. It's been very helpful for them using social media. I would encourage all of you to investigate the social media in your area. I think it's now our responsibility to steer families to good sites rather than to just leave them up to their own devices. There's a great campaign on Instagram called Scars Are Beautiful that builds resilience. You can see a few examples from those posts. And then there's some stars that have shown their scars, like the late Robin Williams and the Boston Celtics basketball player, Jeff Green. Great tattoos in kids with congenital heart disease. I'm always struck with how good they are. This one on the left is my favorite. It's one of the better drawings of tetralogy of flow I've seen. Then there's an artificial heart over there on the right. Okay, I'm going to talk about 2 more things really quickly. The first is dogma, which I believe is the enemy of anti-fragility. And then we're going to talk a little bit about us. I say this frequently because it stuck with me from medical school, where one of my professors said, half of what I'm teaching you is wrong. And the problem is I don't know what half it is. I suggest to all of you who teach to be humble, that what we think we know may not be true all of the time. I was sure that this was all true, sure, when I finished my fellowship and started on staff, that kids with heart disease, most of this I got from Dr. Castaneda, who was one of the best mentors I ever knew, but a good operation fixes everything. Rapid warming is crucial after surgery. Intubation, sedation, neuromuscular blockade for days were necessary to blunt the stress response. We didn't have nitric oxide, so let's hyperventilate the patients. Seizures, Bill Norwood used to call them baby twitches, are not a bad prognostic sign. And cardiac surgeons are good pediatric neurologists. They were frequently not even allowed in many intensive care units because of fear that bad outcomes would be blamed on the cardiac surgery. So what do I think now? And these are things that I'm pretty sure are true. Early extubation is a good idea. That sounds right. High hematocrit bypass is good. The bidirectional Glenn is a good operation in single ventricle. Milrinone's a good drug. Just as I said before, decreasing length of stay will improve long-term outcomes. Goal-directed therapy with NIRS reduces morbidity. Steroids prior to cardiopulmonary bypass are good. Cardiac intensivists are good pediatric neurologists. Now, just like I showed you before, this can't be true. There has to be things, we have to learn more. The dogma should change. And dogma keeps us from being anti-fragile. We work in a stressful environment. The days are long. I'll give you an example. This is the cerebral NIRS on a cardiac surgeon over on the right, Bill Gaynor, and me over there on the left. And when you look down on the NIRS machine, you could see that my NIRS at the end of the day were in the 20s to 30s. And Dr. Gaynor was pretty normal at 58 to 61. I'm sure that others are making funny comments about why my NIRS are low. But after a 24-hour shift, which I don't do anymore, I didn't feel good back then. There's my NIRS there. The ICU is a stressful environment. As I said before, the burnout rate is high. Our circadian rhythm is disrupted. Babies die. Parents are stressed. There are multiple invested caregivers with occasional moral distress. I'm sure your units are like ours, where there's a lot of, quote, politics or ego or system failure. External validation, you did a great job today, Joe, is uncommon. And meals are frequently on the fly. And we do this day after day, month after month, year after year. It's also noisy. A couple good studies on noise exposure. So noise exposure is recommended to be between about 30 and 50 decibels. We know that in most intensive care units, that number is higher. OSHA says it should not be sustained for more than about at 80 decibels. So nurses, if they wear a decibel meter, averaged about 76 decibels per shift. The patients averaged about 60, 55% of the time. It was louder than a passenger car going by you. 9% of the time, it was louder than a truck going by you. And that's equivalent to 6 hours of a vacuum cleaner or 3 months of a heavy truck every 15 minutes in our intensive care unit. The nurses wore Holters in this study, and 1 hour per shift, they had diagnosable tachycardia. Where's the noise come from? I thought it would be the monitors. That was only 3%. It's us. We have our conversations. Then we get louder because the monitor is going off and whatnot. Alarm stress parents. One of my favorite memes. The first time your baby pulls a lead off and all you see is the flat line. Alarm stress parents, they should stress us, but they rarely do because they go off so often that we get monitor fatigue. So what good are they? What else? Stress, infant CPR. When CPR is happening, that's a big stress, not only for the entire team, but all the parents in the unit know that somebody's baby is getting CPR or urgent care, and then they think that could be my baby. That's called vicarious trauma. The fear of fragility is very stressful to us. We know that babies do this. I have that confidence most frequently, but some, especially early career and fellows, will be worried about that fear of fragility. Who's that 10% that's going to go onto CPR? That difference there, that takes time, that sixth sense to develop that. How do you identify this patient from this one? And that's hard, and we don't get it right all the time. Even, even teaching rounds can be stressful when you see the group of us coming up to rounds. We think everything, the attendings, we think everything is perfect. The patient's smiling. They're very happy. The resident and the fellows look at it this way. And the nurses just want to run in the other direction. What's work-life balance? We're going to close with this. Remember when we used to fly? Those days when we used to travel, those were fun. We now call airplanes, or I call airplanes, viral transport medium. But remember what they used to say? Remember what the flight attendant would say to us? Put your own mask on first before assisting others. If we don't take care of ourselves, we are not going to be in this job for the next 5 years, and we're not going to necessarily like what we're doing. So give some thought to focusing on and building your resilience or your own anti-fragility. This, I have to be honest with you, this was my life for about 30 years, where I saw myself as a cardiac intensivist, not a father or a grandfather or an athlete or anything. I was a cardiac intensivist rather than what I did for a job. And that's very different than where I am now. This took a long time and a few bumps in the road to get to this point, where there are other parts that are important to my life on a daily basis. And I'm not saying that these should be equal in the amount of hours. That's not the point. The point is thinking about being present at those things. If I was at my son's lacrosse game, not being on my phone texting, and being 100% present when I was doing what I was doing, which includes when I'm at work, being totally focused. We're not taught how to do this, but there are ways to learn how to build your own anti-fragility. Is your mind full? That's certainly like after rounds. Or are you mindful? Are you paying attention to the trees and to the sun and what's going on in your colleague's life? Work on getting your stress reduction, whether that's through spirituality, and not everyone can have the Pope come visit their NICU, but some NICUs are lucky to have that. Do art, do exercise, do music, do gardening, whatever it is that makes you find joy in life will keep your joy at your work. This is a plug for our musician band. This is cardiac surgeons and pediatric cardiologists. As you can see, we get together and enjoy our own company. And this is a shameless plug. If you plug, all of the proceeds from our album go to the Children's Heart Foundation, which you can find on bit.ly Baby Blue. We used to be the Blue Baby Sound Collective, but the family groups didn't like that. We actually had one group on stage that could have done an entire operation from anesthesia and perfusionist to a scrub nurse. So this is what's going to happen, everybody. This is what you think is going to happen. Your plan, and then God laughs. This is what really happens in life. And be prepared for that. Build your own anti-fragility so that you can sustain these perturbations to the system, which sometimes can be very deep. And finally, about the families, building resilience for them is our responsibility, beginning at admission and long past hospital discharge. Finally, have a plan B. What are you going to do in those 5 or 10 years when you're not working as a healthcare provider? Many of us will be lost. And we know that in particular surgeons, in the first year after retirement have a very high incidence of clinical depression because, like I was, define who they are by what they did. And it's very important to pick up your plan B while you're working so that you can continue that plan B when you're done. This was from the very first Pediatric Cardiac ICU Society meeting in 1996. And all of these people who were doing intensive care unit are no longer doing it full time. There's just a few of us that are, and I had a short break from doing it as well to stay eager and excited to do it. So here's my final thoughts. Think of this more as joy and stress that can accrue at the same time. we can be happy for what happens to our patients, learn about what happens to our patients, especially if you just work in a hospital setting. So this, I've shown this picture a lot, but this baby's getting a Norwood procedure by a medical student who has a Norwood procedure. Not every Fontan has PLA or needs a transplant. In fact, 3/4 of them do not. But if you only work in the hospital, you would never know that. This young baby from the Boston Circulatory Arrest Study went to his prom, got married, had his own baby. If this doesn't bring you joy, I don't know what will. In summary, patients, family, and staff show us yin and yang of fragility and resilience. They're resilient and we're resilient over the short term, but increasingly fragile over the long term. Let's collaborate on solutions. Share seamlessly and steal shamelessly is a motto from the National Pediatric Cardiology Quality Improvement Collaborative. I frequently think about the 3 things that are important to preserve besides myself and my family are preserve myocytes, preserve neurons, and preserve our patients' families. Take care of yourself and your colleagues and have hobbies and be interested and be present for them. Have a plan B. Challenge dogma. If you've always done it that way, it's probably wrong. Be open to change. I hope I've convinced you that shortening length of stay is likely to improve many different outcomes. And then, we've studied risk factors for bad outcomes. I'd like to see us start to move in an area where we study resilience. How is it that some kids who've had a Fontan and 5 operations can become a medical student and others can have significant problems? We study the ones who have the problems. What makes those kids resilient? We have to learn from them. Again, this is another thing I pulled off the website for one of the websites from Red Hat, which is a software designing company. But they look at fragility in orange, what's robust, not forever. If you resist things, you can adapt and have resiliency, but there's still some late perturbations in the system. And maybe we will do our best if we innovate, continue to innovate, both for ourselves and our patients, and become anti-fragile. Last, you can love your work. It will not love you back. Have a plan B. Know what happens in the long run. Experience the joy of what we do. Someone once described working in intensive care as constantly walking up a down escalator. This is resilience. This is getting back to baseline. It's not moving up the stairs. Sometimes it's even worse. And I love the analogy of walking up the downstairs. How do we get ahead of that? That's our jobs for us and for our patients and everyone else. Work on your anti-fragility. Work on your plan B. Taleb said this, anti-fragility is beyond resilience or robustness. The resilience resists shock, stays the same. The anti-fragile gets better. Take stuff out. Be quiet in the ICU. Quiet down your colleagues. Actively listen. Don't just wait for your chance to speak. Actively listen to everyone. Actively listen to and support the families. Take care of yourself. Embrace the joy of what we do. I've said this a few times, and I can't emphasize how important this is. The human heart is such a complex organ, fragile and sturdy, all at once. That's the yin and the yang of this. And then I'll leave you with, these are the lyrics from the song we opened with.
Tomorrow's rain washes stains away. Something in our minds will always stay.
It's one of my favorite songs by Sting. I'd also like to say not only how fragile we are, but how resilient we are as well. Thanks very much for your time, everybody. I'm going to try to answer as many questions as I can.
Amazing talk. Really, really amazing talk. Okay, now we lost Gil. I think he's logging in back soon. But guys, if you have any question, please type on the Q&A box, and Gil is going to be happy to answer you. And I think this was an amazing, amazing talk, and it makes us think about what we should do with your life, with our lives, right?
Yes, I love this this talk by Gil, because it makes real pictures. It's a movie of big experience in the. Welcome back. Welcome.
You're muted.
We are talking wrong about you, so
Yeah.
I think that it make this talk coming from is a very long experience. And he cross part of the pioneeristic moment of congenital disease and surgery and intensive care. He works in the first team group that established the intensivists and the pediatric cardiologists in the ICU. So I think this is coming both from experience, from heart, from a lot of things. And as you say, work together with Professor Castaneda, I think it was an amazing experience. So thanks, Gil. You know that I change a lot of my approach after your talk, because I really believe that we say in Italy, never one joy. If you stay in ICU, you will never have a joy. So you have to work to find joy in all the things that we do. So thank you very much. And if you want, I have the video for the World Congress that you send me and I can send.
I just want to ask Grace what she decided she wants to be if she's not going to be an intensivist.
Oh my God, professionally, I don't have the skills to do anything else. I have a lot of other things that I would love to be, like a surfer. I started my Thai boxing today. I'm training Thai box, but as a
surfer, you could be a professional surfer. That would be ideal. It doesn't matter. You don't see that we are, as physicians, so many of us are perfectionists, right? We do very well at what we do. Even we fall off the surfboard. I have never been on a surfboard, Grace, but I think you should be a surfer.
No, I would be great. But this is true. We are very perfectionists, especially with ourselves. Yeah. We need to be very, very good. It's not about being better than the others. It's just to be good for our patients. And this causes a lot of stress for sure.
So actually, there's a question in the, when I accidentally logged off, unfortunately, a lot of the questions in the chat went away. But one of them that R.T. Sharma asked, does the level of stress get better with years of experience? I think what happens, this is no data, but I think what happens is the people that the stress doesn't get better move to plan B. Because why would you continue to be in a stressful environment? So I think there's a diagnostic test which is called the STATE, which stands for state and trait anxiety. We all have a certain amount of traits. We all know anxious people and non-anxious people. We also know stressed people and not stressed people. We all can have a state of one of those. In other words, somebody's going on ECMO, everybody's going to be anxious. Everybody's going to be stressed. But if you take that stress home, that's your trait, you're not going to last long in this field. So knowing that that's the case, for me, Artie, the stress, I think it falsely got better early in my career. And I think this happens for a lot of people. I was, 5 to 10 years in, and I thought I had this stuff figured out. And then I got humbled pretty quickly that just because Dr. Castaneda taught me something, or I wrote something in a journal, or something else happened, it wasn't always right. And so I started out with, I think it's called the Kruger-Durning effect, where you start out thinking you know a lot more than you do, and then you get humbled. And the question then becomes, now what do you do? Can you accept that, get your humility, listen to people more than you talk, and then come back? Or do you go to your plan B? If you don't have a plan B, now you're in trouble, because now you don't like what you do and you don't know what else you're going to do.
You really inspired us with this topic. Thank you very much.
Oh, thank you. Are there any questions that came up that I missed that I can go another probably till 12:30 Washington time?
Comments, but not a specific. There's a question from Jason. He's asking any advice, tips, or strategies for building team-wide resilience in the CICU, in addition to fostering your own individual resilience?
The first advice is to come to our webinar on December 8th, where Sarah Teal from Children's in Boston will be giving an exact talk on teaching and teamwork. I will say that most teamwork comes with two things. It starts at the top. So the senior people must be willing. I remember when Dr. Castaneda, whenever something went wrong with a patient, publicly, he would say, that's my responsibility. I didn't give you enough instruction. I didn't give you enough detail, even though I may have totally messed up. Now, behind closed doors, he would say, you should have done it this way or that way. But when the boss exudes, this is a team effort, and it stops with me, that's the first place to start. And then the second place, I think, is to have a culture, we talk about it too often as a blame-free culture, where you are in a situation where you can be honest. But what I've been learning over the last few years is how to actively listen. I said it very briefly in my talk that most people don't listen with the intent to understand. They listen with the intent to reply. When is it my turn to talk? And I see that frequently when there's conflict, especially between surgeons and cardiologists or people outside of their own silo. Nobody comes into work and says, I want to do a bad job. So if somebody says this is what happened, listen to that, be curious. That's an interesting perspective. I think that builds teamwork. You can't work on the other members in your team. You can only work on yourself. So if you work on yourself to listen more, that will go a long way.
There's an interesting question, Bill, from the audience saying that mistakes happen from nurses to young residents to experienced senior doctors. How do you handle that in front of the families?
Honesty. That's an easy one. 100% complete honesty. If it happens that the nurse makes the mistake or the junior trainee makes the mistake, I take responsibility to the families. That's our job as the senior people. There's a great acronym that I heard, which was HEAT, which stands for hear, listen, empathize, apologize, which is probably the key thing, and take action. And tell the family that I'm going to look into this and be sure it never happens to another baby. The hear part is to listen and not interrupt. It's hard. To empathize, imagine that it's your baby or your child that happened to. But the key is honesty, in my opinion. These are not based in any data, just Gil's random mumblings or something.
Totally agree. Okay, very nice. Any other question, guys? Please type on the Q&A chat box or on the chat so we can continue this amazing discussion.
All right, now you're going to have that theme in your head all day. I'm going to log off, everybody. Thanks, and we'll see you on December 8th.
Thank you, guys. Don't miss the Dr. Anderson series this Friday. And